Hello and welcome back to the Weatherford College EMS podcast. This is episode 5 where we're going to be talking about MONA and FONA, fentanyl, oxygen, nitro, aspirin, or morphine. This is where education meets experience and textbooks meet the street. I'm your host Tyler Holland. Over here we've got Adam Parrish, Samantha Grimsley. We're going to be kicking off with a crucial chapter for our second semester paramedic students, Pharmacology. This isn't just drug names and dosages. This is about critical thinking, patient impact, and why what you give matters. We're here to break it down, keep it real, and maybe even have a little fun with it. So let's go ahead and get started. MONA or FONA, guys?
Yeah, so I actually am a big advocate on this, and it is all about FONA and walking away from MONA. But I think the biggest thing we have to remember is that isn't even the way the algorithm goes. You don't start with morphine or start with fentanyl.
Right.
I think we have to take it back all the way to the beginning. And realistically, I'm just going to start it off with, let's talk about nitroglycerin for a hot minute.
Sure.
We know because we've beat it into our students' heads from the time they were in EMT, if you're an EMT student with us, all the way into paramedicine, that you have to understand what nitroglycerin is doing. And realistically, we know in these acute coronary syndrome patients, or even in our STEMIs or our non-STEMIs, we have to worry about the O2 demand of that heart. And so nitroglycerin is going to help reduce that preload and allow for that myocardial O2 to happen by vasodilating those coronary arteries and allowing for that improvement of coronary perfusion. I always say it's like taking your foot off the garden hose and opening it up and allowing for everything to start moving. And it's going to help to redistribute that blood to those ischemic zones of where it's needed. And with that, we understand that there's a lot of adverse effects that can happen. One, hypotension is a huge one, so we have to make sure we have taken a blood pressure. I always, and you mentioned it in the last one, I always advocate for taking a accurate blood pressure. Don't rely on your cardiac monitor for this initial one, because gosh forbid you forget that. Mm-hmm. But having that systolic, and I know the textbooks and the drug books, they all change from 90 to 100. We know perfusion status is at 90. I would not toy with a systolic blood pressure of less than that. But then we hear a lot of things about, you can't give nitro if you have an inferior MI, or you've got to suspect a right-sided infarction. And I'm always like, that myth has been debunked.
Yeah. So when we start looking at the different kinds of MIs, one of the reasons why we looked at the inferior and everybody got scared is because when we find that inferior, then we have to really look and see if that's an indication that it may be a right-sided MI. Now we all know that the right side of the heart is the one that accepts the volume in, right? So the right side really, because we talked about this on day 1 of cardiology, that the filling of blood inside the right ventricle is a 70% passive thing. So because of that, it is preload dependent.
Yep.
Okay, that preload is what is putting all of that blood into the heart on the right side. And so everybody was worried that if we vasodilate somebody out too much, that preload will dissipate, and that if we don't have enough filling, then again we won't have enough output. And if we don't have the output, then we lower the blood pressure, and this then leads down a rabbit hole that we don't really want to go down. Now, what we have found though is some of that can be true when we're talking about the administering 400 mics at one time of nitro.
Mm-hmm.
Now we have the bottle here, and one of the big reasons we have that here is because what I like to talk about is we can take that bottle and we can start a line on somebody, start an IV, and we can give them a much lower dose. We can go all the way down to like 2 mics per minute or something, And over that minute, if we're at 2 mics per minute, over that whole hour, we're only giving a total of 120 mics in 1 hour versus 400 right now.
Yeah.
Right? And so patients can really benefit from some of this. And now, one of the things, and I know I'm getting off on nitro here, but in conjunction with nitro, or with morphine rather, morphine leads to hypotension way more than fentanyl will when we start talking about just treating those things, treating the pain. I mean, it used to be something that we would sit around and we would all say, if we can treat the pain and get them to feel better, that's what's going to lower the heart rate.
Right.
And what's nice about lowering the heart rate in this case is that every beat of that hurting heart is hurting itself.
Mm-hmm.
And so if we can lower the stress response, then that leads to nothing but good things, right? The biggest problem, though, is as we add certain things to our tool chest, we also get different ideas and different thinking and different benefits. And some of those benefits, especially with we were talking about MONA versus FONA, is that with fentanyl, it's much less of a chance to become hypotensive than with morphine.
Mm-hmm.
And that's a big one, especially when we're looking at things like right-sided MIs. Now, on the other hand, though, morphine has a couple of other issues.
We'll talk about those. Let's not get ahead of the car. We're still talking about nitroglycerin for a second.
So
I want to back up because you are going a little more forward than I'm ready to jump into yet. That being said, on the right side, and we're talking about they have that reduction because of the right ventricle and preload, and we know that nitroglycerin reduces preload. The fix to that is to give them fluids to offset this reduction that's going to happen.
Mm-hmm.
So if you give them fluid, now I'm not saying let's go crazy and dump 1,000 into them and call it a day, 250 mLs to 500 mLs to help, offset and give a little volume there to take the hit when we reduce that preload is exceptionally okay. Okay, so that is where I have to stress that mythical thing that people tell you, you can't do that, you can't do that. No, you can. You just have to be smarter about it. And with nitroglycerin, we'll talk about another disease process before we end it today, coming back to CHF, which we talked about in a few podcasts beforehand when we were talking about Lasix. But with nitroglycerin comes aspirin. And aspirin is crucial for our STEMI patients. We give it in acute coronary syndrome patients as well, in our angina patients, and pretty much anytime somebody says their chest hurts, the first thing the hospital's going to ask you when you call in is, did you give aspirin? Mm-hmm. Not to say that not everybody needs it, but it's not always the right thing to give, because we do know there are some patients out there that have some contraindications to that. But we also know that it's going to inhibit that platelet aggregation by blocking A2, and it's going to slow the growth of the clot and reduce mortality. So as we're vasodilating those coronary arteries, when we give the medication that makes your platelets go from being sticky to less sticky, it's now like you can go down the water slide with the inner tube instead of being beached inside the inner tube.
Yeah, there's I've gone on to several talks from several different cardiologists, and just because again I'm a nerd and love this stuff, there is a contention that says that really the best thing we do is to give aspirin.
Yep.
100%.
Because of exactly what Sam was talking about, and that really ultimately leads to positive outcomes.
Even if the patient can't get nitro, if we can kind of maybe dislodge or push something along the way, we're getting a little bit more. And so one of the questions I always ask students at the end of second semester is, if they were given aspirin at home, or they took their own aspirin, or they take a daily aspirin. Now let's just say this isn't dispatch told them to take aspirin, but they're on a daily aspirin. Do we give it? when we get there? And the answer is yes.
Absolutely.
You don't know if their medication is in date, hasn't been outdated. It's the same thing with with nitro, not morphine, excuse me, but with nitroglycerin. We always come in there and we give them ours, and they're like, "Oh, I already took a bunch." And you're like, "Okay, well, let me give you one of ours." We don't know that theirs hasn't been exposed to the sun because we know it doesn't like to be in sunlight. That's why you have to keep your bottles in a cover, or the bags are off color, the sprays are off color, the vials that we give our sublinguals are off, everything like that, because it doesn't like sunlight and it will lose its potency when it's exposed to that. The same thing goes with aspirin. We don't know what their aspirin is like. Did they take a full strength? How much did they actually take? And everything of that sort. How long ago did they take it? So let's repeat the dose because it's still beneficial. Now, that being said, we don't want to give it to somebody who has a GI bleed or known allergy or peptic ulcers, because that's not the best thing that they need to be on. But, that is the one thing I always ask students is, okay, well, your patient took, aspirin this morning and it's 4:00 in the afternoon. What are you going to do about it? And they're like, well, I'm not going to give it to them because they've already taken it. No, give it to them.
Absolutely. The toxic level for aspirin is very high. It's about 150 milligrams per kilo. So we're in the adult patient, we are not going to get anywhere near it just because they've had 2 doses of their aspirin.
Yeah. And don't get in the habit of just grabbing the bottle and putting 4 in your hand and giving it to them. I have been in situations where the package was a full 324 milligrams for just 1 pill. Mm-hmm. And then I've been in other situations where it's changed. You've got to make sure you're writing your medication and looking at those concentrations and not just, doing the old school, here's the box color, pull the box down kind of thing. So when we talk about MONA and FONA, the biggest thing that I always get into is, what is worse, what is better. MONA is what we traditionally all know and is still out there, but we are seeing a jump into FONA. And I think it becomes, what is the role of morphine in ACS patients? We know that it has principles of reducing preload and afterload, which can help with the myocardial oxygen demand, but it also plays a big component on the central nervous system and our respiratory, and can depress our respirations. It can depress the central nervous system, which is going to now affect everything that we're trying to fix on the cardiac side. So now we're going to ask the heart to work even more because the CNS system is being depressed. And so that doesn't make things great, but there's also some evidence out there that shows that morphine can increase the infarct size. And if that's what we're not wanting to happen, why give something that's going to make it worse? What's your guys' take on that?
Yeah, and some of the other things, some of the things that I really look at when we're talking about morphine or MONA versus FONA, it's really the idea of morphine versus fentanyl, right? That's the F in FONA. Mm-hmm. And morphine's an old school drug. We know a lot about it. We know that it works. We know that it has some benefits. We also know that it has some drawbacks. And one of the reasons why it's not being used as much in the pre-hospital for even just analgesic effects is because it'll also create a release of histamine. Mm-hmm. And if we have that release of histamine, it's going to mimic an allergic reaction.
Yep.
And we all know that with an allergic reaction, we again start looking at like a hypotensive issue. Mm-hmm. So not only is the narcotic going to suppress the CNS, but we have a whole nother realm of issues that start happening within these patients. And that's a lot different to then diagnose. We don't necessarily know, is this hypotension from the narcotic? Is it from the release of histamine, and now we got to give them some Benadryl? And then for everybody is going to be reacting differently. So it's not going to be the top of mind that, oh, they're hypotensive, give them some Benadryl and maybe that'll fix it.
Yeah.
and so because of these things, right? It's hard to consider every little thing. And the other problem with morphine is that it'll slow down your GI.
Yes, and you got to give something for that. You have to consider the fact that they're going to get nauseous, they're probably going to vomit. And then we also know a contraindication to giving Zofran is prolonged QT syndrome.
That's right.
And that's why you can only go 2 dosages, and it has to be a significant time apart because we don't want to have anything going on. If we already have some issues going on with the heart, we're looking at a bigger complication there.
Even though there are some studies out there that say that 2 doses of Zofran are no big deal. There is no reason for us to be nudging it that way either, especially if they already have a prolonged QT, or if we don't know, why they're in this situation in the first place. If we can't tell, we don't need to be encouraging. Essentially, we don't need to be trying to get that to happen. And one of the other problems with morphine, I'm looking here, and it's talking about morphine administration along with platelet counts. Mm-hmm. And actually, with morphine administration, it's been shown versus non-morphine, so fentanyl and even none, that within the first hour you have a higher platelet count than with non-morphine. Which is exactly what we're trying to stop. That's what the aspirin is for.
And when we're giving morphine, we're not giving it. We know that its mechanism of action will reduce preload and afterload and allow that O2 demand, but that's not why we're giving it.
Correct.
We're giving it for the analgesic aspect of fixing pain. It just happens to do the other. But we're already giving that with nitro. So like you said, it's going to cause them to become hypotensive. Well, we already have a patient who's possibly going to be becoming hypotensive from giving our vasodilator. What is the body's natural reaction? Increase the heart rate. This heart rate does not need to be increased, which is going to just ask for more O2 demand. And now we're just chasing the tail at this point. That's why fentanyl becomes a really good alternative, because it doesn't have some of the same properties as morphine in the sense that it's not going to affect the GI system as much. It's got a little bit of a faster onset of action and a shorter duration of action, but it doesn't trigger that histamine release. And that means we're not looking at more of a hypotensive patient. Now, it can happen, but it's not going to be as dramatic as we see with morphine. And so if we're looking at why we're doing it for the analgesic aspect, that's why fentanyl is more likely to be seen over morphine. And heed you not, I've even had students tell me, well, we're giving aspirin for the pain. We are absolutely not giving aspirin for the pain. It is for the platelets, and that is what is being given for. So please understand that in that aspect.
So just to really set in stone these points that y'all are making, one of the NIH, once again, NIH guys, one of the studies says right here that the use of morphine either alone or in combo with nitroglycerin was associated with a higher mortality with these STEMI patients, or in STEMI patients, either way. So why are we still giving it?
That's an excellent question.
I think it's just one of those things where it was the tradition, and so that's what we know, right? That's what everybody is. It's those same old medical directors who haven't gotten off the horse, where they're still giving nitro to reduce the blood pressure and aren't looking at the dynamic of why we're doing what we're doing and the harm that it can cause these patients. It's the same thing as us hearing, well, I put oxygen on the patient because I put oxygen on the patient. They need it. They have a STEMI. They need oxygen. No, they don't. I read charts all day long, and SpO2 is 96%, and they've got a nasal cannula on, and I'm why? For comfort measures. That's not a comfort measure. You're harming more than anything, and especially when we talk about acute coronary syndrome. Your textbook and the American Heart Association, they preach 94% oxygen, but when we're talking STEMI and we're talking American Heart Association, really the threshold then becomes 90% at that point. While National Registry isn't quite to that standard yet, they're making those changes of getting to that standard. But realistically, if you think about it, as we're breathing in this room right now, we've got 21% FiO2 in our atmospheric oxygen, right? So if we apply a nasal cannula, let's just say 4 liters per minute, because we know 2 to 6 or 1 to 6 is anywhere from 22 to 44% oxygen. Well, now we're hypersaturating this patient at that 4 liters by nasal cannula. Well, our body isn't used to this oversaturation, so it's going to react, right? Now it's got this extra, and we've talked about it in IAP when we talked about free radicals and it releasing, and knowing that oxygen is not a stable element. It has to attach to something, and it usually doesn't attach to another stable element. If we increase these elements and give more than what we need, we are releasing more of these free radicals, and that in a sense is also going to result in vasoconstriction, which is something we also don't want when we're dealing with a STEMI patient. So we're just making this worse. So if we don't see a patient who is physically showing us signs of respiratory distress and their oxygen sat is not less than 94%, putting them on supplemental oxygen is the wrong thing to be doing, and your medical directors need to start considering that, and you as a provider need to start thinking about the why behind what you're doing and the harm you could potentially be doing to this heart that's already damaged or becoming injured in that sense. So just applying it to make you feel better or make the patient feel better, that's not the justification there. That's not why we do it. So that's my soapbox on that aspect. Before we're done, I want to jump over to CHF, but do you guys have anything to add on the acute coronary syndrome side of things?
Go ahead, Adam.
Oh, yeah. So the only thing I want to reiterate is when trying to, or when speaking between both MONA and FONA, the next question is, okay, so, but which one solves pain the best? Right?
Fentanyl.
They've actually shown that fentanyl and morphine can be just as effective as each other. So there is no reason to be using the morphine in and of itself as a painkiller.
Yeah.
If you're going to say that the analgesic effects are equal, then there's no big reason then why you should lean more towards MONA. If we've already said we've got all these things wrong with morphine, and we've gone down that rabbit hole, and then you say, but wait, there's one more. They're still hurting. Which one works best? They both work equally as well in terms of just straight analgesia in the ACS patient.
Yeah. I was just going to add, this is from the International Journal of Paramedicine, which I think is cool, right, guys? We have our own international journal. So, and it's just comparing strictly fentanyl versus morphine in your STEMI patients and its vasoactive properties, right? The blood pressure and everything. So it's just saying here that fentanyl is not going to have as much of a vasoactive property to it. It's not going to have a depressive effect on our systolic and diastolic blood pressures. And also, really, my favorite part of this study is saying that an unanticipated finding from the study is that paramedics, without a guideline to do so, used fentanyl instead of morphine if they suspected that the blood pressure may decline. So without any medical direction, anybody telling them what to do, they chose fentanyl using our paramedic knowledge, right? And ultimately benefited the patient in that regard.
So one of the things I started looking up was we know for our pain management, ketamine is a player in this, but does it have a seat at the table with our ACS patients? And I can't find anything that says, do it.
Well, my concern for that is just simply patient assessment. When you start to get into a dissociative and you arrive at the hospital and you're trying to get a good patient assessment, the hospital staff might not be able to come to the conclusions that they need to. Maybe there's a question that you didn't ask before you gave that ketamine that really needs to be answered. And if it's hitting that dissociative, you kind of maybe absorbed a little bit too much too quickly, and now the pain management is, it's controlled, but now we're dissociating.
Yeah.
Those questions might not get answered, and that can be very important.
Kind of reminds you of like the don't give your patient with abdominal pain medication because it can't locate the exact area of it, right? My biggest thing is I always hear people say, well, ketamine causes hypertension. Well, it doesn't technically cause hypertension. It can just increase your MAP. And those are things we have to worry about, but we don't want to increase that in these patients because we already know we've got O2 demand that needs to be reduced, not added to. So that's why we aren't probably going to look at using ketamine in these patients just to, answer any questions that might be there, or somebody just decides, well, hey, I've got a hypotensive patient. I can give ketamine because that's the opposite of what I'm looking for in these patients, right? That's not correct. And so just to address anything there.
Yeah, and the treatment for these patients is dependent on patient interaction.
Yep.
Right? If you start going down that route, we know how ketamine works. We know that it blocks the NMDA receptor sites, and NMDA is responsible just for like neuroplasticity and creating memories, things like that. And because of that, if you're going to give somebody something and say, okay, do you feel better or do you not? If they are unable to answer that because they are in this state of dissociation, this is not going to help us even in pre-hospital. Even if we're just talking about 20, 30 minutes, every time we give a nitro, we want to know, did that help or did it not? We want to know, hey, is this helping your breathing? Is it not? We want to know, is it getting worse or is it not? We want to know everything about that patient, and because of those effects, that's not going to be the ideal way to go.
Yeah. So the big question becomes, when we're talking about switching gears from acute coronary syndrome into CHF, where does nitro work in this equation?
Well, have you heard the term third spacing?
Tell me about it, Adam.
It's the wonderful thing that we're going to do to our CHF patients. And nitro makes it all possible. Now, it's not the only thing. We got to have a few other things going for us. But really, nitro in and of itself with CHF patients, we're giving it, number one, let's start at number one first.
Left-sided heart failure.
Left-sided heart failure, and they have to be able to reasonably maintain their blood pressure.
Mm-hmm.
Right? We don't need to show up and give the hypotensive patient a bunch of nitro saying we're going to third space you and whatever. Well, they could still, their MAP goes too low, their brain stops perfusing, and nothing good happens after that, right?
Yep.
But all that being said, so we're assuming that their pressure can sustain it. Let's say they're hypertensive, as a lot of these patients are going to be. They can't breathe very well, and we say, hey, let's strap this thing to their face and let's blow all this air in there, and so we're going to apply our CPAP.
Yep. And
that's going to help cause so much pressure in the lungs that it's going to help push some of that out. That's all well and good. We high five everybody. We did it.
Yeah.
Well, where does that fluid go?
Everywhere else.
How can we increase the capacity for the body to be able to accept or move any of this fluid out of the way so that we can get it out of where we need it to be out of? Because honestly, at that point, we're down to, if we don't have an airway, if we don't have breathing, if we don't have circulation, we don't have a patient.
Yep.
So I don't care where that fluid is going at all.
Mm-hmm.
I want to give this nitro, which is going to vasodilate your patient out, which means they can have more fluid in the vasculature. It gives it a place to go. You are creating a third space. You are creating additional space to be able to move that fluid out and push it out of where you don't want it.
And what did we talk about in that one podcast? It's not a volume overload problem. It's a volume distribution problem.
It's just dealing with what they have. And so it's giving it more space for them to deal with it in the interim. Because we have to understand that, as they can't move that fluid around, it sits there. And when it sits there, it'll just start accumulating. Well, as it accumulates, we can influence some of that accumulation, but it has to go somewhere. And so we have to create a space for it. And that's that third spacing.
In the other spectrum of things, when we talk about CHF, we know the golden ticket is CPAP and going into BiPAP, but nonetheless, the second drug that we used to utilize after nitroglycerin was morphine.
Yeah.
And so, Adam, you talked about it earlier in relation to the histamine release that occurs from morphine. That can be very detrimental to our CHF patients.
It could very well be, yes.
And so we know that with morphine, it has those vasodilatory effects. And that's great and everything, especially when we have these pulmonary edema patients that need that vasodilation. It also can help reduce some anxiety and things of that sort because it's suppressing that central nervous system. And these patients may be a little bit, anxious because maybe they can't breathe or something of that sort. But remember, I always tell people hypoxia is, or patients are altered because they're hypoxic until proven otherwise. That's the biggest thing, right? So that's not the reason I would want to give morphine is to reduce anxiety level, but that could be a side effect to it. But nonetheless, morphine is almost coming out of this as well when we talk about CHF patients, specifically to our pulmonary edema patients. We're not really seeing it as the golden ticket there as much anymore. Do you have anything on that?
Not a ton. You've covered most of that. One of the big things when we start talking about fluid overload and dealing with all of that is that we don't really want to increase the heart rate that much.
Right.
Yeah.
And again, going back to, and I know we've hounded on this many times, the compensatory mechanism for hypotension is an increased heart rate. And that's exactly not what we want.
Yeah. It's interesting because you're the historian, but I found a study that said that in acute pulmonary edema patients treated in the emergency department, they found a significant increase in the number of intubations and ICU admissions in patients that were given morphine to CHFers.
Wow.
So, the studies are coming out, they're there, but nonetheless, is there anything that you guys want to add to this? I know it's a quicker topic than some of the other ones we've talked about, and these aren't drugs that are new to our paramedic students nonetheless, but it still plays an important talk. I think the biggest thing that I always want to hit home on, especially with nitroglycerin, is you have to ask your patients about those contraindications, those erectile dysfunction drugs. And a lot of people just get embarrassed or they do the assumption of there's no way my patient is taking that, or even that my patient's a female, there's no way that they would be taking that. And y'all, I cannot stress it enough. You have to be assessing these patients and doing a thorough job of writing your medications before you give them, because it will be you that just makes that, oops, I didn't ask, and next thing we know, that's where we're at.
Oh yeah, definitely. And just to reiterate what you had said at the beginning, why are we talking about is it MONA or FONA when nitro and aspirin are the ones that we need to be given first, right? Aspirin is our key drug in this situation. If you're not giving aspirin, it doesn't matter what else you're giving.
Yep.
At all. When it is a blood clot issue, aspirin's going to help prevent it from getting worse.
Yeah, especially because we don't know if the blood clot was a DVT or something that broke loose, and that's where it traveled to, so just because, when we're talking about these infarcts and injuries and things that are going on in the heart, it doesn't always mean that it's a fat emboli or a blood clot. It could be something else that's going on when we don't know, because we don't have that ability. Our job is to treat and recognize what's going on and get them to the appropriate place, which is a cath lab of some sort or interventional treatment to get that started. But yeah, that's the stuff that I really wanted to take home on these medications. Do y'all have anything else you guys want to add to this?
Not really. I think the only, well, yes. Now that I think about it, so one of the things that I have found helpful, just in my experience, has been if obviously we need to do our 12 lead EKG before we start giving nitro. Still give the aspirin.
Yes.
Do that quickly. Get your line going, and have your partner hook up the 12 lead and get that cooking real fast. And by real fast, I mean the industry is moving towards a 5-minute EKG. Within the very first 5 minutes of you telling dispatch, "Hey, I'm here," within 5 minutes you need a 12 lead and potentially a right-sided or posterior. You need to have all that done, so you kind of have a better understanding of what's happening. One of the things is that sometimes you're going to find that by giving that nitro, your ST elevation may disappear. Okay, there's a couple of there's a couple of arteries around the heart that will spasm.
Mm-hmm.
And that spasm is causing the ST elevation. And that ST elevation will just be will be taken care of because the nitro will open everything up, it will relax a little bit, and then poof, it'll go away. And then a bunch of their symptoms will resolve. The reason why you need to have that on your EKG is because if you show up to the doctor and you're like, "Doctor, I promise this is what I saw," they're going to look at you, roll your eyes, and say, "Yeah, okay, whatever."
Yeah.
Right? So it's really important that you do these things in the correct steps. I know you talked about it right off the bat.
Yep.
You don't just show up and start slinging fentanyl or morphine first, right?
Woo! It's a party.
And so just to reiterate, right? It's very important that you get that first 12 lead before you start throwing nitro around. It's really important that you follow the operating order of things, and that this is just simply, it's not a do this, do this, do this. This is just simply, a way to remember kind of these are a few of the things that we got to do.
And reassessment is huge between all of those interventions. You've got to constantly be reassessing these patients.
Yeah, absolutely. And, and even something as simple as carrying like a pen on you so that you can label your 12 leads and label whatever, that's going to come in handy too, especially if you do find that MI. You're doing these serial 12 leads and looking at it over and over to see what your medications are doing. You want to have them labeled, and so that you can show and you can keep track of everything. Because you'll get to the hospital, I don't care if
it'll all be
10 or 15 minute transport. You'll get to the hospital, you'll have 5 or 6 or 7, because you're just like, okay, what do I do now? 12 lead. That sounds like a good plan.
Yeah, don't take your 12 lead off once you get these. I mean, if you have a patient where you're just taking a 12 lead to take a 12 lead, maybe ruling out in a syncopal episode or something like that, okay, sure. But in these patients, leave it on, and also put your pads on your patient. You never know what's going to happen. And even to this day, I still get students who will send me pictures of their 12 leads, and they're like, look at this, it's happening, and they're watching the progression of it. What was just a normal 12 lead, I hate the word normal, but what was just a regular typical 12 lead, all of a sudden patient starts progressively getting worse, and they're watching their patient, read your patient, not the monitor. They're watching their patient, let me get another 12 lead, let me get another, and they're just seeing it transpirally happening right in front of them. And that comes back to being that, don't be, reactive to the situation, be proactive and planning ahead of what you should be doing for these patients. Because we've said it before in one of the other podcasts is, unless it's physically happening in front of us, we don't know anything. And so that's where we're at with that. Do y'all have anything else that you want to add?
I think that sums it up.
All right, well, that's a wrap on this episode of the Weatherford College EMS podcast when we talk about acute coronary syndrome and CHF. It's a big thanks for tuning in as we kicked off this pharmacology topic. The next podcast, we're going to start transitioning out of cardiac medications and into some respiratory medications, so keep tuned on that. Nevertheless, this is a topic that can feel intimidating, but we promise it does get clearer with every call and every repetition, from Tyler, the NIH man, and Adam, the historian, to myself. We're here to guide you through it every step of the way. Stay curious, ask questions, and never stop connecting those dots between the medications, the pathophysiology, and the patient. Until next time, stay safe, stay smart, don't forget it, and just know it's not about knowing the drugs, it's about knowing what they do and why they do it. Have a great day, everyone.